we will be discussing the Medicare cost sharing issue. And for the public, this issue has been brought before the board over the last month and a half or so. And it relates to an issue with the Medicare co-insurance rules for critical access hospitals. In short, if the critical access hospital charge masters exceed the allowed amounts for Medicare, a patient's copay is quite a bit higher than it would be at a PPS or larger hospital system. In effect, we're seeing rural Vermont seniors potentially pay more money than they should for procedures and out-of-pocket costs. And we're also, as a result of that, seeing less Medicare money being brought in to support our healthcare system. So today's hearing is a result of a series of letters and engagement between the board and our critical access hospitals for two purposes. One was to provide further information and understanding of this issue and this dynamic, which is a dynamic that is being experienced nationally. So first and foremost, we want to understand what is going on and what the implications are, not just for the patients, but also for our hospitals. And second, the purpose was to find a solution. And not find a solution a year from now or 2 years from now or somebody else's solution, but here in Vermont to find a solution now. Because no one in this hearing wants to see our rural seniors who are vulnerable paying more money than they should. And no one in this hearing wants to see us in Vermont receiving less federal support than we should. It's clear from the hospital's engagement with us that they are partners in this and that they want to solve this problem just as much as we do, and that we are going to. It is also clear that this problem will take really, really hard work very fast. There is risk, there is complexity, and we're going to work together and find a solution to it. There are some solutions that the board brought to hospitals to get feedback on. We're going to discuss those more today, and we'll discuss any other ideas and solutions that the hospitals and the Association of Hospitals has come together to provide to us. So with that overview, I want to turn it over to our Director of Policy, Ms. Barabee, who's been our lead here at the board on many of our most pressing issues, and also this one. She will provide an overview of this issue and some more deeper background for table setting. And then I hope to have an engagement, further engagement with our partner hospitals on discussing the ramifications to their hospital of this issue and their community members and their patients, and also the solutions. So just for the agenda, Ms. Barabee will walk us through some history. We'll then bring up some of the information that's been brought before us. We want the hospitals to participate with us in explaining some of the information and to then walk through and discuss possible solutions as a sort of public work group, if you will. So Ms. Barabee, I'll turn it to you.
Great, thank you. Can everyone see the slides? Okay,
yes.
Great. Great. So we'll be talking, as Chair Foster mentioned, about the Medicare cost sharing policy and how it affects patients receiving care for outpatient services at critical access hospitals. So this came to us through a public comment, and I can't share any further detail because there was a lot of personally identifiable information. But this Vermonter was covered by traditional fee-for-service Medicare as the first payer, and they had an outpatient knee replacement at a Vermont Critical Access Hospital in 2025. When they received their bill, they noted that the patient share was substantial, so close to $11,000. This is simplified for the purposes today, and that the Medicare total payment was close to $48,000. They also kind of did some more investigating and found that had they received this same care at a non-critical access or a PPS hospital, that they would have only paid their patient share would have been capped at $1,600 or almost $1,700, and that the total Medicare payment was substantially lower at $14,000. So when they have the choice to go to different hospitals, may be paying very different prices, out of pocket, and also that Medicare payment is quite different. So we wanted to better understand what was going on here. And what we found is that under federal law, patients pay more when accessing services at critical access hospitals because of a particular cost sharing rule. So those hospitals that are reimbursed under the OPPS system, the outpatient prospective payment system, pay 20% coinsurance on the Medicare allowed amount. So that's the total amount that the hospital receives from Medicare. And it cannot be greater, as I mentioned before, than this $1,676, as was established in 2025, which is the Medicare inpatient deductible. In critical access hospitals, however, beneficiaries are liable for 20% coinsurance on the basis of hospitals' charges. So not what Medicare pays the hospital, and there's no kind of cap in this scenario. So the hospital charges for those folks who aren't living in the billing world are really synonymous with the list price. So it's not reflective of the actual cost. When you go buy a car, there's this price, and that is not often the price you pay. You negotiate discounts from those prices, hypothetical prices. And so in this case, the patient is paying 20% from that hypothetical price. Just so this is clear, this is an illustrative example. I know there's a lot going on here. So you'll have a PPS hospital on the left, critical access hospitals on the right. And this kind of demonstrates the same logic that I just shared with you in the previous slide. So on the right, you'll see that critical access hospitals are reimbursed at 101% of costs. So I think Medicare, as I'll go into the subsequent slides, recognizes that we need to pay more for some of our, access in more rural areas that have lower volumes, that may have higher fixed costs, and this makes sense to make sure that our most rural residents continue to have access to care. So they pay 101% of costs. They have generally higher payment than their PPS equivalent. But in this case, you'll see in the list price column, the patient is paying 20% of that list price, which is often much, much higher than the price that they actually receive from the payer. On the left block, you'll see a similar layout for PPS hospitals, which are paid a lower amount for a similar service, and the patient is liable for the 20% of the actual amount that Medicare reimburses. So again, this is just illustrative generalities. There are certainly variations across services and across hospitals. It depends on what the hospital's costs are, where they establish their list prices, etc. So a very brief history. There's a lot of text here for folks who want to get into the weeds, but it's important to know that this is not a kind of intentional decision. So there were a number of rural hospital closures in the 80s, and this is where the critical access designation came from and was established to make sure that we retained access in our most vulnerable communities. At that time, much of the reimbursements were based on charges, and they were at the time much closer to costs. When Medicare rolled out the OPPS system, so later in the 2000s, critical access hospitals were excluded from that change. So though most hospitals moved to the cost sharing rule where it's 20% of actual paid amounts, the critical access hospitals retained that 20% of charges rule. So this is a legacy rule. It's not a new rule. It has been around for many decades. And then in 2014, the OIG noted how much, the disparity in this population and how much more these patients were paying. And then again, MedPAC raised this issue just recently last year in their report to Congress, highlighting that, critical access charge masters are often between 2 and 11.5 times the Medicare fee schedule. So it's quite a bit higher than the PPS hospitals, and just highlighting the magnitude of this issue. So you'll find in subsequent slides, we'll talk about, how this varies by state, but on average, critical access coinsurance is around 52% of Medicare payments. That means that patients are paying approximately 52% of the total bill. And that's kind of comparable to the 20% of the bill paid in a PPS hospital. Again, the magnitude of the price is also quite different. So they're paying more and often on higher priced items. So this example, again, illustrative, kind of takes the the knee replacement example, and shows kind of what happens as charges grow. So in the top bar, the assumption here is that your charge, the critical access charge master, is equal to the Medicare payment. So we know that doesn't happen often, but should they be equal, the patient would pay 20% of the total Medicare amount. The second bar, so coming down a level, assumes that the critical access charges are 2.5 times the total Medicare payment. This would be approximately 50-50 cost share for patients and Medicare for that total 41,000. And it's important to note the hospital receives the exact same amount in each of these scenarios, so nothing is changing on the hospital side. What's changing is who's paying the bill. When you get to 5 times the total Medicare payment and above, the patient assumes 100% of the responsibility. So in cases where it's beyond 5 times, which, you know, as we noted before, there are some charge masters like 11 times, patients actually end up subsidizing Medicare. So the hospital sends back a payment for those overages to Medicare. So they're paying more than the hospital actually receives. And then again, this is compared to kind of the lowest bar at the bottom is the PPS hospital, where the patient would be capped at that 1676. So even 20%, not liable for that full 20%, but just that deductible. So how big is this issue? So as I mentioned before, on average, beneficiaries receiving services at critical access hospitals have about 52% cost share. That's, you know, almost double or more than double the 20% standard cost share that has been even capped on the PPS side. So as I noted before, cost sharing varies greatly depending on the charges. So this is based on the MedPAC report to Congress. You know, critical access hospitals with the lowest charges, so the bottom decile, still had copays of around 33%. Those with the highest charges, so the top 10%, had copays of higher than 80%. In the most extreme situation, so that situation where I described earlier, the patient is actually subsidizing Medicare, that happens in about 4% of cases, so about 1 million outpatient services annually across the nation. So this is a national statistic. And again, you know, it certainly varies by state. So I borrowed this from Marilyn Bartlett's presentation just a few weeks ago to the House Healthcare Committee. You know, Vermont has an average of 48%, so just below that 52% average cost share. There are certainly other states well below and other states well above this cost share, but it does still kind of beg the question about how much patients are responsible for. And this isn't just, you know, I've been using the word patients, but I think it's, you know, patients often have secondary insurance when they are Medicare beneficiaries. So around 84% of rural beneficiaries in the Medicare fee-for-service program have supplemental insurance of some kind. So when that coinsurance increases, the burden gets pushed onto Medigap or employer-based insurance through higher premiums. And also in some cases, if Medicaid is the secondary payer, can result in higher state spending unless there are explicit protections in place to ensure that states are paying lesser of. In that case, I do believe, depending on how exactly it's set up, there may be a gap in the revenue received by the hospital. And then 15% of rural beneficiaries, again, this national statistic on average, do not have supplemental insurance. And I think this might be larger in Vermont. So where do we go from here? You know, I think important to start with the MedPAC recommendation. So Congress, they kind of recommended to Congress to set the copay to 20% of cost-based hospital payment. So that is kind of that higher amount that would keep hospitals whole, but reduce the patient share to 20% of the total paid amount to critical access hospitals. But they also indicate and recommend a cap in the same amount, the 1676, like PPS hospitals. This would be a modest increase in cost to Medicare, so around 2.1 billion annually increase in claims. We also know this could offset bad debt and free care, so that's also a factor, but still kind of a substantial price tag for them to implement this. And this would result in reasonable copays for rural seniors and kind of get more parity across the system, especially if you have this cap. I think patients would be paying the same regardless of whether they went to a critical access hospital or to a PPS hospital. And again, the critical access total reimbursement for outpatient services in this recommendation would remain unchanged. As Chair Foster mentioned, we sent a letter asking for more information. This just details out the specific questions that we ask. So I'll just briefly review this for the public and others who have not followed as closely. So we would like to understand when charge masters exceed fee-for-service payment amounts for outpatient services, the extent to which this is happening across services and across hospitals. An understanding of cost sharing differences experienced by patients and their supplemental plans due to charges exceeding the fee-for-service Medicare rates. So are they actually on the hook for this amount? And then calculate the revenue impact to the hospital if charges were reduced to the fee-for-service payment amounts. And then provide input on possible solutions. We outlined 3, which I'll return to later. But one is, if we were as a state to reduce charges to the fee-for-service, or I should say the cost-based reimbursement for critical access hospitals, B, to reduce to the OPPS rates, so the rates that other hospitals are receiving, or C, exploring what would happen if we capped patient cost sharing at 20% of either of those reference points, or other solutions. So if there are other solutions hospitals have, this would certainly be a time to bring them into the conversation. We also had a question to our insurers who offer supplemental products to help us understand the extent to which they are observing this phenomenon in their claims. So I'll just do a high-level overview of what we heard, and then I think we really should hear from hospitals on, and we will hear later today on what their advice back to us in answering some of these questions and finding possible solutions. So I think they reiterated that charge masters often exceed fee-for-service rates. They have difficulty in calculating the cost-sharing difference. Charge reductions, if done in this way, would be financially devastating. I think a lot of this had to do with having loss of revenue associated with commercial contracts. They advised us that federal law constrains unilateral state action. So I think particularly around the third option, where we were proposing to cap what patients would pay, would kind of run counter to some of the Medicare rules themselves, which require hospitals to collect from patients. And then I think most of our hospitals, if not all of them, pointed to kind of the congressional approach as their preferred method of action, and then called for a collaborative working group. So I'm glad we're all here today to continue that part of the work. We also heard from Blue Cross, who shared quite a bit of interesting information, and we can hear more from them as well. So in their analysis, looking at January through September claims, CAUSE represented about 23% of total Medicare supplemental payments. 95% of COP payments were for outpatient facility claims. It's quite a large proportion. The average co-insurance is kind of on par with what we've seen at the state level, around 46%. And certainly ranges across hospitals from 38 to over 60%. And then we found that 71% of outpatient COG claims had coinsurance above that 20%, which is not surprising. And they estimated that capping coinsurance at 20% would have directly reduced out-of-pocket costs by 11% for this population. So now I will walk briefly through kind of the options and kind of turn it back over, I believe, to Chair Foster to facilitate some of this conversation. So, just so we're clear on the proposed state solutions that we put on the table so far, option A was really to reduce the hospital charges to the Medicare cost-based reimbursement. So this is what critical access hospitals receive overall from Medicare. This would lower the patient share. So instead of having the 20% attached to charges. It would be attached to the costs of delivering that care and the amount that hospitals receive. This could have either a neutral or lower hospital revenue implication. So if hospitals were not able to renegotiate their contracts as a percentage of that cost-based reimbursement, and that would presumably, I think, change the amount of revenue they could bring in from commercial payers. That's some of what we heard, but would be good to explore that further. The impact to Medicare, so this would directly offset, so this really cost shifting back from patients to Medicare. Medicare would be assuming a greater proportion of that payment where they're currently paying, 50% or less of that payment. Option B is roughly equivalent in approach, but it would bring charges down to the outpatient prospective payment equivalent. So this is how other hospitals in Vermont and elsewhere are being paid. This would, again, lower the patient share, back to this OPPS allowed amount. Again, the same kind of caveats for hospital overall revenue impact, and Medicare share would increase commensurate with the reduction. In option C, so this is where we were talking about capping the patient cost share. This would certainly lower the patient share, but would necessitate lower hospital revenue. I think the Medicare reimbursement would still work off of the 20% of charges, and so there may be a gap in the amount hospitals would receive. And then certainly we're open to discussing other options not yet presented. So I will pause here, answer any questions, or turn it back over to you, Chair Foster.
Thank you. That was really an exceptional summary, Ms. Barabee, so thank you for putting in the time to do that. I think it really encapsulated all the issues quite well. I'll start with some, I guess, questions for Voz and some of the hospitals, just to kind of flesh out some of these issues, and then I'll turn it to the other board members. The first question I had is relating to the concern about the financial risks if we here in Vermont were to address this problem. And I guess I'll focus in on option A that was outlined in my letter of February 18th and here on the present slide, which was reduce hospital charges to Medicare cost-based reimbursement. As Ms. Barabee outlined, this would solve the problem, I think, entirely of the amount of money that our patients are paying for services at cause. And as I understand the feedback from the stakeholders, the risk was really on the commercial side if we were to reduce charge masters. So I'll open it up, and I guess I have a two-part question. The first question is, am I correct that if we took option A, the financial impact to our critical access hospitals on Medicare patients would be negligible, if any? Am I correct in that?
Chair Foster, this is Mike Del Trecco. I think I don't know that we know that to answer your direct question, but I also think I would ask. So I'm going to start by saying, hey, we're all in on this, and I want to reiterate the seriousness of this issue, and we suggested coming together in this fashion back in February. And I want to share with the group that we're not only concerned about Medicare beneficiaries, but like you, are focused deeply on affordability and focused on our affordability action plan, which that has three components to that. That literally last year took out $230 million out of our operating expenses. I don't know that any industry in the state of Vermont has done that. So it's just demonstrating that we are committed to solving all of these problems. I think the commitment to reduce more funding and more spending and lowering our charges is part of all of this work. But I don't know that we have an answer to any of these options that are here. One very significant question that we have, and this is where we've taken some action here and tried to get some solutions and answers from our federal partners that we have yet to achieve. I think the language that is being used to maximize Medicare payments or reimbursement or support while lowering Medicare cost share are two very specific compliance concerns that we have around where the OIG has responded that this would be against sort of Medicare rules and regulation. And it was detailed in our correspondence on February 27. So to take some proactive steps, because we want to understand these questions and answers and how they impact this compliance issue specifically, I reached out to our Medicare administrative contractor for guidance. And for those that aren't aware, the MAC, as they're referred to, is responsible for managing critical access enrollment, processing claims, settling annual cost reports based on reasonable costs, not PPS or prospective payments. And then they also work to verify that critical access hospitals are in compliance with their bed limits and length of stay limits. During that conversation, the MAC corresponded that, boy, this would change and manipulate Medicare cost reports in a way that they didn't feel comfortable with. They acknowledged they necessarily weren't experts in the federal regulatory space and referred us to CMS. We have been in contact with put in contact with the CMS regional office, and we have yet to hear back any further guidance. And I clearly would invite you to, and anyone from the board's team here, to participate in those conversations as we move forward. I also think it's important to note that while this is an important issue, the expectation for critical access hospitals to answer these questions is largely not achievable. So critical access hospitals are paid cost-based, not fee-for-service, and there's no historical or compelling reason for those organizations to understand how to calculate the Medicare fee-for-service and or ops equivalent payments. So these are really difficult questions to answer. We don't have this capability internally, and even throughout the state, when this happens, most hire outsource very large consulting firms to help with this work. So because we rely on Medicare regulation, because this compliance issue is deeply concerning, I'm not sure that the demand of coming up with the solution today, and for that matter, coming up with a solution for fiscal year 2027 budgets is something that is possible. And it's not because of a delay tactic. It's not because we're not concerned. It's because we primarily need to answer, do any of these changes put any one of our critical access hospitals in violation of federal regulation or create a compliance issue for them? If they have a compliance issue, that's a massive problem for any one of these organizations. And as you know, every one of our organizations is leaning in on affordability, whether it's discussions around S190 or H585. So we're doing the work here, and we're kind of at a shoestring and stretched pretty thin. So I think that's why partnership is important in this space. And I actually think that without standing those federal compliance implications in a way that could further destabilize our hospitals here, we've got a real problem. And so again, we've proactively reached out to our federal partners, and additionally, we've reached out to our federal delegation to say, hey, we need to lean in on this. We need to solve this for not only Vermont's seniors, who we care deeply about, but all seniors across the country. And I think this warrants a national solution. And I would question or advise moving in any option A, B, or C in the moment without understanding the compliance implications fully would be super problematic. So I'm happy to answer any questions But as I look at all of the questions outlined in 1 through 5, it doesn't take us long to get to, we don't even know these critical access hospitals internally with VAS. We don't have the expertise or experience to calculate rates to cost-based rates to ops equivalents. And I can certainly say if all charges went to Medicare fee for service, or all payments went to Medicare fee for service, every one of these 8 hospitals would be in deep financial pain and problematic, and not be there for their communities for the long term. So happy to answer any questions. I wish I had a better answer for you. I wish I had a better answer for this national issue that I think Elena's slide depicted when they made the decision on critical access hospitals. There was an intentional decision made to save the federal government monies. And because the thought was supplemental insurance would pick this up and Medicare beneficiaries would not cover the cost of that. So I'll stop there. Happy to answer any questions, and whatever else you may have or desire from VAS in the moment.
Great, thank you. Thank you for the prefatory remarks. I think they're important. We're obviously all very concerned about the financial state of our hospitals here in Vermont, something the board's worked on with you and everyone for a number of years now. And so I think the goal of the solutions is to find a path where it is not financially destabilizing, but at the same time, we're not sending our rural seniors into financial ruin either, because this is incredibly destabilizing to families who are paying exorbitant amounts. And frankly, one of my concerns is that it is a giant sustainability risk for our critical access hospitals. I keep in mind, the board cannot approve budgets legally that are not transparent, not fair, not equitable. And so my concern is that we have, excuse me, don't interrupt, please. You can speak after I speak. My concern is we're going to have these charge masters and have an issue where it's not an equitable way to finance the hospital system, or that it's not transparent. And if it becomes transparent, which it needs to be, patients will not want to go to our critical access hospitals because they're going to know they're going to be paying higher supplemental insurance costs or out-of-pocket costs. So it's also a risk financially to the sustainability of our critical access hospitals, which we at the board really do not want and have made a lot of effort to sustain our critical access hospitals. I appreciate that there are other complexities to this. And so the goal of this is to get those out on the table, to identify them, to write them down, and to track them down and get the answers. So that if there is a path that we can take together, we can do it. So why don't we start? I think your feedback is really, really valuable and important. But I think the first question, if somebody could take notes, maybe at VAS, and we'll I'm sure have our own, and we'll probably have a transcript of this, or at least a recording. The first thing would be, what are the federal compliance risks? So on option A, I don't read the federal regs to require charge masters to increase at a particular level, or that they need to be 2.5 or 5 or 10 times Medicare allowed amounts. So I think there is some volition and opportunity to consider what are the right levels of charge masters. So the first question, I think, under this one would be your point, Mr. Del Trecco, which is, are there compliance risks on the federal side to lowering charge masters? If you know the answer now, that's great. And if not, the point of this hearing is to get it out there and get feedback and get the answers. So I guess somebody needs to write down question 1. What are the federal compliance risks, if any, to option A? And my first question that started this discussion was, what is the impact to Medicare patients' revenue? Sorry, what is the impact of Medicare revenue if charge masters were reduced? And Ms. Barabee put up a slide, and I wanted to verify it. It was a slide with the various ratios, the 1-to-1, 1-to-2.5, 1-to-10. And her presentation said the Medicare revenue on those patients would be 0 financial impact to hospitals, but a huge financial benefit to our rural community members. So my second question is that correct? If the charge masters were reduced and we just shifted the amount of the copay, would the hospitals have any financial loss? And then my third question relating to option A, gets into the other, what I understand to be the financial risks that hospitals are concerned about, which is on the commercial side. And the question there is, what is the impact and what are the barriers to a solution? As I see it sitting here today and after reading the correspondence, which was very helpful, yes, I agree. If there's a change in the charge master and there's not a change in the discount off charges or how you negotiate the actual amounts you're being paid by commercial, that would be financially risky, to say the least. But is there an opportunity to change the structure of how you're paid by commercial? If you need a multiplier off charges, is that something that's possible? Have those conversations started? Sitting here, I'm not a hospital administrator. I don't work in an insurance company. I never have. But as a somewhat of a layman in this context, I don't understand why an insurance company wouldn't agree to pay the exact same amount of money, just structured a different way. And our hospital budget guidance, I think, is being voted on maybe tomorrow, and the staff recommendation was -1%. So the hospitals would go to the insurance companies and say, hey, can we have 1% less money next year on our rates? And we might have to call it something different or structure it different, but can you pay us 1% less? I'm not really sure why an insurance company might say no to that, but maybe there's a reason. I see Ms. Heinz has her hands up, but I interrupted Mr. Del Trecco. So Mike, if you have something further on that, I think it's a good time.
Yeah, I just wanted to comment. I thought you paused and were waiting for a dialogue. No intent to interrupt.
No problem. Did you have something you want to share?
Yeah, so I think all of those questions are good, and one of the things that I am concerned about, and you've heard me say it already, but I would like to know your thoughts and the board's thoughts on the compliance risk, if you've looked at it all in this space, because that's for us, and that's why we've been fairly proactive in reaching out to our federal partners and our delegation to say, hey, what can we do? What's in the art of possible here? Do you think that there is compliance risk here or not? Because that's important for us to sort of understand as we approach some of these questions.
I don't think I or the board, and maybe I can't speak for everyone, but I don't know that we've come to a conclusion as to whether or not there's a compliance risk on the federal side. So we are looking for more feedback as to what the compliance barriers might be on the federal side and the possible solutions to them. And when you say compliance risk, are you referring to option A or just in general?
So when I read the HHS OIG position, it's fairly clear, or I think it's clear to me. Let me just phrase it that way. When the OIG opined on how the equaling effect that we're talking about here, if prices were lowered and Medicare paid more, and then the benefit accrued to the Medicare beneficiary through a reduction in cost sharing, those two things, I think, precisely are what OIG spoke to. And then therein lies the challenges around evaluating option A, B, and C. And again, so that's why we've reached out, and I invite you to those meetings when they happen. We know sometimes CMS operates not as fast as we would like them to, but we continue to push them for that answer.
Yeah, and that was something I struggled with, which was there was certainly never a requirement for the charge masters to exceed at this rate. I believe that's correct, but correct me if I'm wrong. So what I don't understand with the OIG opinion and position is if hospitals had essentially any opportunity to change their charge masters how they wanted, why can't it be done in inverse? I think what they're really getting at is obviously they don't want an intentional effort to inappropriately shift the cost sharing burden to Medicare. I don't know that I see this as an inappropriate change. It actually would have been the exact same structure had the charge masters not increased at an exorbitant rate. So if we need to get clarity from OIG, we certainly should. But again, it's just another item on the path towards a solution. Or I think we need to be really transparent with the public and the community that while we all recognize this, and I very, very much appreciate that the board, the public, and the hospitals have recognized this is not optimal for the state or our patients. We need to come together and publicly say, we did all the diligence necessary and we could not find a solution, and here's why. But I think we owe it to the community to take all those steps, and I appreciate that you are and that you're taking this so seriously. Ms. Heinz?
Rebecca Heinz, Blue Cross Blue Shield. I do just want to point out that, Blue Cross, first of all, Blue Cross pays these hospitals discount off charge. So we would need to return, the current payments into fee schedules, which is a ton of work, but is not impossible. But I want to point out that a rational insurer that's not so interested in the critical access hospital's financial positions would just pay the charge. Like, why do it? Why have a contract? If you can get the Medicare rate with no contract, that's the rational thing to do. So I do think that the charge master impact on the commercial revenue side is something that needs to be thought about and addressed.
Most certainly. I mean, if that's not how we're doing it now, changing it to a fee schedule or a multiplier off charges, then we certainly do need to. And I think the point here is, have we done that? Have we started reaching out to the insurers, at least the major insurers, to start that discussion? Because I can't imagine that insurers want to see any financial ruin at our hospitals either. It's not good for an insurer if we have financial ruin at any hospital. And if they're going to pay the same amount, then we need to work with them. And if there's regulatory efforts that can be made by the state, the care board, DFR, whatever it is, then that's something on our plate to start looking at and evaluating. But I think at this point, it's very, very important, given the timing, that those conversations have already happened or started to happen with the insurers. We need to take these issues, put them on a list, and knock them out. And we cannot go to the public and say we did not do that. Mr. Fisher?
Yeah, to that point exactly, I just wanted to add to your questions. What are the limits or the ability for DFR to have an influence or a regulatory power over third-party administrators? I think we've got the influence over fully regulated insurers. I'm wondering how we get to the rest of the market. And Rebecca, I don't know if you have an answer or perspective on that, but that's just another question about how do we really affect this change?
Yeah, I mean, I would think you'd have to set the rate. I do think as you start to get to insurers that are more national in focus and have more and mostly or exclusively self-funded business, it does get more complicated. I also will note that if you wanted to focus on the med sup market, which is fully insured, we aren't the biggest payer in that market currently.
So same question, what's DFR's power to drive this?
I think that's an open question on the TPA side.
Great. And Mr. Fisher, we'll put that on our list to reach out to our colleagues there to explore that. There's going to be things that everyone has to do here to run this to ground, and that's one of ours. Relating, I'll turn it, I don't mean to hog the questions here from the start, but we do have to take our statutory obligations seriously. We cannot approve budgets that do not comply with the statutes. And one of the guiding principles in our statutory requirements is transparency. And I personally did not know about this issue until this year. Maybe there had been some kind of generalized awareness potentially, and I don't know, but here at the board. And I guess on the hospital side, you can fill me in if I'm incorrect, but I'm going to assume either you didn't know or this wasn't a burning issue on the hospital side. I'm not going to make you answer the question at this time, but either way, it is now before us. And consistent with transparency, don't we need to tell the rural patients that if they go to a critical access hospital, they will have to pay a larger amount than if they do not? How can we not inform our community members of this disparity? I guess I'll ask it more pointedly. Would VAS and the hospitals support some sort of notice to rural seniors about this financial impact that they may see at a rural hospital? Mr. Wooden?
Yeah, I love that idea if you do it for all charges and all issues, Owen. So if you're going to just say, well, we're only looking at critical access hospitals, and we're going to, with transparency, using the word transparency, say that we want to warn you that it's more expensive. Why not do that across the board for all services and all payers and all situations? Because otherwise it sort of feels like you're just focusing in on critical access hospitals, but which only constitute about 20% of the entire state's hospital budget. And it sort of really puts them in bad light when in fact, you know what I mean? Why not be transparent on all issues? Why just sort of pick on the critical access hospitals? Most of these patients, like 85%, as we know, have other co-insurance in ways in which they can have those charges reduced. They also get discounts for prompt payment. There's bad debt. So there's other ways, but I'm open to the idea if you consistently and fairly do it across the board. Those are my thoughts. Thank you.
Yeah, and I think you're correct. As I read the statutes, there's certainly no distinction on the transparency requirement as to the payer or the hospital, right? The transparency requirement in the financing of our healthcare system is across the board, across payers, across hospitals. So you're entirely correct. It would need to be as to all payer. And of course, there's price transparency rules and requirements that are already there on the commercial side. And I don't think you were suggesting this at all, but the board has certainly been very, very invested in making sure the commercial costs of our hospital system are transparent. I don't think UVM Medical Center would dispute that the board has been taking a lot of effort to shine a light on some of the pricing on the commercial side at the medical center. And in fact, I think we've encouraged your hospital, Mr. Wooden, and Northwestern, and others that have lower commercial prices and Blue Cross Blue Shield, we've encouraged quite strongly to be transparent and tell the community there are different prices for different services, and they should be a part of your decision-making in selecting where you get your healthcare, along with quality, convenience, access, and everything else. But your point is very, very well taken, and I think it's a legal requirement myself. Mr. Del Trecco.
Thank you, Chair Foster. I was just going to mention the transparency rules that you mentioned. So I don't think there's an intent to be not transparent. Every hospital has a portal that patients can go into, look at pricing, look at cost sharing amounts. It's not as specific as what you've just described, but I think that is in play and maybe could be improved.
Maybe look, there's a perfect solution out there potentially. Maybe it's not attainable, but there are other lesser solutions that do get to some of these problems. And at least transparency, one, I think it's legally required, but two, maybe it's something we can do if there are in fact compliance risks on the federal side that we've run to ground. So I'd put that on our list. What can we do to improve transparency as to rural seniors and the copay amounts? And also to Mr. Wooden's point, all costs. I think that's something that we can certainly improve upon. I'm going to assume that the hospitals didn't know this was happening to the community members. We didn't know. There's no way that community members know that their co-insurance costs are going to be potentially a lot higher. If this room didn't know about it, at least in this level of detail, the public doesn't either. And that means we are failing transparency. So we all collectively might need to take some steps on that. One question I did have in the last letter, in the invitation for the meeting was, I would like to avoid a regulatory solution. That doesn't mean the board might not consider one. We do think this is really critical. We do think this is in tension with Vermont law, at least I do anyway. So the question I had was, what would the critical access hospitals and VAs want to see in our guidance to provide sufficient notice of a potential regulatory solution? And you might not have an answer now, but I'm going to tee it back up on our list to provide the board feedback really promptly on that, because we're voting out guidance by the 31st. What would the notice need to be for critical access hospitals? I don't want an appeal later on down the road where there's a concern about notice. That'd be a waste of legal fees that could be spent solving the problem or lowering costs or whatever it would be. It'd be a waste of our time. It'd be a waste of the court's time. So at a minimum, I want to make sure that we have sufficient notice in our guidance. And if there's different notice that the hospitals think is important for option A, B, C, or some other proposal, you can distinguish it. But we definitely need to make sure that you are on sufficient notice that there could be a potential regulatory solution. Understanding there's a long time between now and when the board makes any decisions on budgets, but we don't want anyone to come by surprise. And hopefully we can come to a solution, the best solution we possibly can, so that it's not a regulatory solution, because it is true, the best part of Vermont is working together for the community. So let's solve this and not go there. But if we need to, we definitely need at this time, we have a time pressure to make sure we have that in our guidance. I'll stop there for now and I'll open up to the other board members. Dr. Merman was very, very interested in this issue and has done a ton of work. So I'll start with Dr. Merman if he has any comments, thoughts, or questions.
Yeah, thanks, Rowan. I have a few follow-up questions in this conversation, which one is, the first one is, Ms. Del Trecco, I was trying to think about the regulatory concerns about hospital charges. Does Medicare direct hospital to set their charges in any way?
Dr. Merman, I could barely hear you. I'm sorry, I had a truck going behind me.
Oh, okay, sorry, I'm glad it's not my mic. So my question was, do you know if Medicare directs hospitals to set charges in any particular way?
I'm not familiar or able to answer the question in the moment. Sorry.
Okay, I was gonna say, I've never heard in reading through this material that Medicare directs hospitals to set charges. I think that would be kind of out of the scope of Medicare. But my impression with that is that and this is going to, I guess, be a follow up, and I can follow up with this too, and find out more. But would Medicare has allowed, I don't think Medicare has a role in this. So Medicare has not done anything to negate the increase of charges at hospitals, nor the variable difference between hospital to hospital or sort of percent of Medicare. And I think that's discussed in the OIG report, that there's, a huge variance in charges. So I would think that Medicare wouldn't have any role. And when hospitals go, maybe I can ask a hospital, I think there's some critical access hospital CFOs on the call, but do you know if, when you work on your charge master, does Medicare have any comments on your charge master when you adjust your charge master to, say, a board order, or when you're looking to rebalance your charge master?
Dr. Merman, this is Mike Del Trecco. The one thing that I read in this language, which is part of why we've reached out, is if we are lowering charges with the intent of changing or manipulating might be too strong of a word, changing with the intent of improving Medicare reimbursement and or lowering cost sharing amounts creates a problem. So I'm not that sure that there's a specific answer to, hey, the normal course of business in your charge master, but very specifically with the intent of changing cost sharing amounts has been discussed from the OIG's point of view. And again, it's a question that Chair Foster has outlined, and we are actively seeking guidance and clarity on.
Okay. Thank you for that. There's one other thing I want to clarify. I think you misspoke earlier. You said that critical access hospitals aren't paid fee for service, but I believe they're paid fee for service within the cost-based reimbursement methodology. They're not on a global budget, as far as you're aware, are they?
They're not on a global budget, but their reimbursement is based on their actual costs and then settled at the end of the fiscal year cost reporting, which is 9/30, to settle up those costs.
Okay, so not OPPS, but in the cost-based reimbursement, but attached to a service, a fee for a service.
Reconciled back to actual costs under sequestration. So not OPPS, not your traditional Medicare fee-for-service payment structure on inpatient and outpatient. That is different on the professional side.
One other kind of reflection on this conversation right now is that I think one of the reasons, Mr. Wooden, that this has risen to being such an important issue is that there's about $100 million of Part B Medicare supplemental claims per year in Vermont, at least according to the cost report data. And about 50% of those are at critical access hospitals. And I think we would assume that the critical access hospitals provide a lot less than 50% of the outpatient services. At least that appears to be the case. So I think that's why this particular issue has such a large magnitude, as it is that a very small percentage of hospitals are accounting for a very large percent of these Medigap, Medicare supplemental payments. And while it's been mentioned several times here that people have a supplemental payer, patients pay the supplemental payment. So it's not that that is just some bucket of money that's available to them through another source. That's money that they're paying. So it's directly related to the patient expense. I'm just going to go through my notes here. So I actually really, and I really do want to second Owen's initial remarks that I think that I have a lot of concern about the risk to sustainability of our critical access hospitals with this as well. I think that there's some distortion here that could really impact our critical access hospitals in the long term. And I really worry about the communities of which they're in and the amount of subsidization that's coming from the patients to the hospital and their local community that I think we thought was really coming from Medicare. I agree that this is ideally, and I think as everyone else agrees, I would love a federal solution for this. I would love the feds to just pony up a couple $2 billion and invest that money into our rural hospitals. I think that would be the easiest, quickest, nicest, cleanest solution. But I also agree with Chair Foster that our Medicare beneficiaries, largely seniors, some others, are being pretty, especially those in rural areas, are really being impacted by this policy, and it's affecting Vermont in a unique way because while nationally we look 47%, similar to the other states on that chart that Elena put up, we have much higher rates of services delivered in these communities. So nationally, 5% of Medicare spending is at critical access hospitals. In Vermont, it's 22%. So we are a much higher risk. We are much more sitting out on the edge here, and our seniors are very exposed to this problem.
Sorry for the inconvenience. But yeah.
There's someone else who is.
I mean, yeah.
I think there's someone else who's got a live mic if you want to get it.
I think it's been shut off.
Thanks. So I want to just sort of expand a little bit more on the comment of Medigap plans before I talk about another potential option, which is And Mr. Whitten, you brought this up at the last meeting we had of a friend who had a $10,000 bill, and your recommendation was that all Vermonters should have traditional Medicare with a Medigap plan. And that may be the future because Medicare Advantage to a large degree has left Vermont. But nationally, and I don't know the Vermont data, a little bit less than half of Medicare beneficiaries live on $46,000 a year. So you add another $400 a month of a Medigap plan or $4,800 a year, that's like 10% of their gross income is now being paid towards a Medigap plan. So these plan premiums really do impact people. Taking 10% of their income and putting into healthcare in Vermont, you can imagine with next winter coming, and we have high oil prices that probably won't come back down that to what they were. People are going to have to make tough decisions about what they can afford and their basic needs. But I want to throw out another option, and I don't know, Abby, I had sent you a couple slides. I don't know if that's possible for you could pop up the slides. If not, I can share them.
Let me check. Yep, pulling those up right now.
Great, thank you. Thanks. If you could go to well, this one actually, we can start here. This first one's kind of interesting. So this slide is from the cost of freight data, 2021 on the left, 2024 on the right. This is cause Medicare payments to total payments to cause. And this is from the cost reports. So it's what's in there. The green is patient share, the blue is what Medicare pays. And so you can see in Vermont from 2021 to 2024, the green boxes grow faster than the blue boxes. So patient cost sharing has increased pretty significantly from 21 to 24. So the light blue at the top is actually inpatient. So you can see that the Medicare payments for inpatient care has declined, and the little thin green one below that, that's inpatient copays. They have declined. But the two bottom boxes, the dark blue and the bolder green, I would say, are outpatient. And you can see the growth of outpatient services in Vermont cause, and you can see the impact on the green box at the bottom goes from about $20 million to about $50 million in outpatient co-payments. So while the hospitals have grown Medicare revenue by almost $45 million, 64% of that has been in co-payments from outpatient services. So this is really impactful. If you could go to the next slide. So Jeff Stensland, who was at a prior meeting of ours and then was at the House Health hearing a couple weeks ago on this topic, cited a figure from the MedPAC report that basically a PPS payment is about 60% of a CAW payment on average for all services, inpatient and outpatient across the country. So the top row here is the CAW payment. So that's 100%. This is not a dollar amount. This is the percentage amount. And the bottom row is the PPS payment, 60% of the 100%. And for the average hospital in Vermont, with 47% coming from the patient, you can see the green box on the top is 47% of the CAW payment is coming from the patient, and 53% is coming from the federal government, federal money. In the bottom, you can see the PPS payment, where you have 20% comes from the patient. Maybe. This is an uncapped service.
I can hear it. I know.
This is one where you have the 1676 copay.
Hey, Abby. Abby.
There you go.
Yes.
And you just run muted, Abby. That's fine. And 80% comes from the federal government. So this is sort of the average payment, the average hospital in Vermont. Abby, can you go to the next slide? So this is the hospital in Vermont with the highest charges, and where 69% of the payment comes from the patient and 31% of the payment comes from the feds, compared to that PPS payment. So it's kind of surprising, and it was a little shocking to me to think that if this hospital had a PPS payment system, they would actually be getting more money from the federal government than as a critical access hospital, which was pretty mind-blowing to me. I had assumed that when we were talking about, I've been a huge advocate actually for shifting services to critical access hospitals in a way to get more federal money to support our anchor institutions in our rural communities. But this scenario looks actually like the anchor institution in our rural communities being heavily subsidized by the local population through either their Medigap plans or their Medicare payments, co-payments, and a PPS payment would actually be potentially more federal money coming into that hospital. Less total money, but more federal money. Mr. Costa, did you want to comment on this? I'd love some insight into it.
Oh, I'm Michael Acosta, CEO, Gifford Healthcare. Appreciate board members really wrestling with this. If it's okay, I just have a quick question on the slide deck. On the first slide, was that 2011 or 2021?
Sorry, 2011.
2011. And is it inflation adjusted at all? Because 100 million in 2011 would be about 145 million in 2024. So I'm just trying to figure out whether it's inflation adjusted or not.
No, it's not inflation adjusted. That's true dollars. But my interest in that was actually not showing the increase in total Medicare payments, which actually seems fairly reasonable to me. It's the distribution of where the source of that payment is coming from was sort of the take home on that slide, that this is being pushed more onto the patient, not onto and less onto the federal government.
Good. Thank you.
Yep. Abby, you can take down the slides if you like. So I think the other option that we should kind of throw on the table here, which has been discussed over the years, is whether or not a PPS payment system would make sense for a couple of our critical access hospitals. And the one that the MedPAC report discusses is actually the rural emergency hospital system, where hospitals would get 105% of OPPS for outpatient services and then get a $4 million payment to cover fixed costs. Now, what they lose on that is inpatient care. They lose the ability to have inpatient bills, but they can keep patients in observation for periods of time. It's an average length of stay of 24 hours, but that, from the way I read it, that includes all patients that are arrived. So if you have an ER and you have a lot of arrivals, the average of 24 hours isn't too bad. And that does not include patients who are being transferred out. So when we talk about all these various options, and I think we can come to a place where we can reduce charges and work with the insurers to maintain commercial revenue, there is this other option that I think we should start to think about and throw on the table, which I have honestly not been supportive of until I realized the impact of this payment methodology on our local communities. So I'd like to just throw that one on the table as well. And one last comment on this topic that I think comes from working as a physician. I assume as administrators, you all recognize that physicians often really struggle with the concept of burdening our patients with high bills. It's something that, people who go into being frontline providers, typically speaking, are, looking to provide services. And of course, you're probably highly aware that, billing is something that we, and coding is something that we tend to not feel particularly comfortable with. And there is sort of this concept of that's troubling is when you're providing care to a patient that you could be financially harming them. So about a decade ago, maybe a little bit less, there was this phrase that was this isn't coming from the hospital system I work for. This is coming from sort of the press within my field, of the idea of you're not billing patients, you're just getting credit for the work we do. You want to be credited for what you do. And this this convenient phrase moves this kind of removes the financial component of the billing process and makes it about getting, being measured in productivity. You want to make sure your productivity measurements relate to the hard work you do every day. And so this phrase has become pretty ubiquitous, at least in emergency medicine. And the irony of this is actually, I found out that this phrase actually came from the United Healthcare's physician group Optum, as a way to kind of convince physicians that they can bill more and not feel bad about it. And I would just sort of also say, like, as a physician community, I think this kind of comes out a little bit on the comments that are made today, is that we often look at insurers and the federal governments as sort of pots of money that we can draw from to keep our practices and hospitals sustainable. And they're sort of dehumanized. They're not individuals. We're just taking this pool of money and trying to make sure that we can get it to our organization or our department to sustain the services that we're working really hard to provide. The problem with that is actually, especially within the Medigap market, is that the premiums are really paid for by the patients in your region, in the region that they're living in. So it's really explicit in the Medigap market that premiums are a reflection of claims. I think this whole issue has really been challenging because it's kind of flipped the narrative of how critical access hospitals are being funded in my mind. That I thought we as a state and as a community we're trying to maximize our revenue from Medicare to provide it for our communities. But now that the veil has been pulled back on this, I think this is really complicated. And you see the last graph I put up where, at one hospital in Vermont, patients are paying 69% of that Medicare payment amount. I really do think this needs to be remedied. I really do think, Mike, that we can work together with the hospitals and the insurers to come up with a rational solution to lower charges, to go back to what the critical access hospital intention was, which was to have additional federal funding to support these rural hospitals. I don't have any further questions at this moment, but I do have a lot of general questions that I think we can continue to have a conversation about. Mike, sorry I missed you.
Mr. Costa, your hand is raised.
Yes, thank you very much. If I may, I just would like to make a few comments. I think, just to back up a little bit, I appreciate the conversation that we're having today. And I just want to say something really plainly. Like, we, of course, share your concern. And I've been so grateful that the chair has acknowledged that. When we care for a senior in Randolph or Royalton, and they get a bill that's higher than what they expected or higher than what their neighbor might pay, we know that's a problem. And it's not just a policy problem, it's a community problem. And these are our neighbors. We care for them every day. So like all the other Vermont hospitals, where Gifford stands is completely clear. We want to find a path that brings healthcare costs down over time. Full stop. But the conversation today really resonates with me because I wonder if we have the information to act as quickly as people would want. I'm struck by the number of questions that we're not able to answer at this time. I'm struck by the fact that we're talking about a system that was not designed by the state of Vermont or Gifford. It's a federal Medicare policy that applies to every critical access hospital in all 50 states. It's one that we're required to participate in. And today, when we're talking, I have so many questions based on the slides and the information I've seen. For example, I think they may assume that we get paid 100% of charges. That's not the case. It lacks an analysis of how much charity care and bad debt might come into the equation. I think there's now a suggestion on the table that we might close our inpatient units. And I think that for us, this is exactly why Gifford and other critical access hospitals wanting to meaningfully participate in a work group. We wanted to come together, put all these ideas on the table and try to make the progress that the board clearly desires and Vermonters deserve, either in terms of solution or transparency. I still think there's time for that. I want to be really careful that we don't, because of our desire to do something quickly, we don't get it wrong. My professional experience is that speed is the enemy of thoughtful analysis. This is clearly a complicated issue. Gifford stands ready to take action with you, but I'm just struck that we may need, I still think in my heart of hearts that we need a more formal way of trying to work collaboratively on this. And I would urge the board to reconsider its decision not to participate in a work group with all of us on this. Thank you.
Very much the point for this hearing in the letters is that we can get the information. It's just a question of what are the right questions, what are the answers, and the point here is to do exactly what you're suggesting. And I would just comment, we are getting it wrong. It is wrong. So your point about like getting the solution wrong, the status quo is decidedly wrong. So we're going to have to work with those two tensions and get to the right outcome. 100%, the point here is that you can send a letter, we can get the questions asked, we can get the questions answered. That is our responsibility. The critical access hospitals, we have supported them very thoroughly since I've been at the board. They are an incredibly important aspect of our health system and for our rural communities. Part of caring for our community is making sure they can afford healthcare. Part of making sure that our hospitals, our rural hospitals in particular, are here is making sure the care is affordable. We are seeing it on the QHP side as expenses rise, patients drop insurance. As those Medi-Sup plans rise, patients drop Medi-Sup. As Medicare Advantage goes, people go without coverage. So it is also equally a concern for affordability as sustainability. So we do need to get to a solution, and asking the right questions is an incredibly important part of that.
Right. Can I just throw one comment in just to reply back on that? Mr. Costa, I don't think anything here is implied that you all get 100% of charges. I don't think any slide refers to 100% of charges. The one I had was 100% of the Medicare critical access hospital payment amount was the 100%, not 100% of charges. And I don't think any of the slides that Ms. Barabay put up referred to 100% of charges. I do think the concept, the language around charges and prices does get slipped up often. Mr. Del Trecco had a slip up earlier and said prices instead of charges at one point. So it's a nuanced, there's a lot of language and it gets a little bit sticky, but I don't think any of these slides look at, assume at any point that a critical access hospital or really any hospital gets 100% of this charges. I think it's been described more as the charge as sort of the list price that really seems to be not associated to or not directly correlated, or at least very lowly correlated to costs. And with regards to just closing inpatient units, that was my referral probably to the rural emergency hospitals. I think that's just one more solution that the MedPAC report cites. And I think that if we're going to go down this process of transformation, that solution previously, it looks very unattractive to me because it undid the benefit of the cost-based reimbursement. But what I am now seeing is the benefit of the cost-based reimbursement. A lot of it actually is potential risk to the community. So it would be a very specific application for a specific place, one that may do very little inpatient care, but it should probably be rethought about. I read the letter from the rural health consultant previously, and it seemed to miss a lot of the details of what the rural emergency hospital program can do, and have some skimped over some of, I think, the important parts in there. So I think it should be thought about, again, not for hospital budget guidance in 2027, clearly. So, but thank you.
Thank you.
And I do consider this our work group. I don't know if everyone's familiar with the laws governing how the board has to operate, but we can't meet 5 of us privately with anybody. We can't even speak with the 5 of us about regulatory issues on our own. Every board member, to my knowledge, is very, very keenly concerned about this issue. So we would have a process where 2 people could go, the other 3 couldn't. It'd have to get brought back in a public hearing. And the other point is, we want the public's input. We want the public's participation. They're a stakeholder too. So this is the work group. I'd really love to see VAWS can have its own work groups. If you want to come together and create a chart of steps that need to be taken, questions that need to be asked. If you have to reach out to the insurers to start that dialogue, when are the letters going? When are the communications happening? If the insurers refuse, send us back feedback saying these insurers refuse to pay us -1% next year, whatever it is. Let's start ticking off the issues so that we can at least get as close as we possibly can through a non-regulatory solution. A provider-led solution, I think, will be the right solution here. Ms. Heinz? Rebecca? I see a hand raised on a phone number as well. Last 4 digits, 3256. Oh, that's you, Rebecca. Go ahead.
We need to unmute it for her.
Okay. I don't want to gloss over one of the things that was brought up in the comments and that I think is a real thing, which is there isn't currently a PPS to critical access hospital price comparison mechanism. That the outpatient services, as we all know, are paid differently on the PPS side. It's a totally different system. And that's something we're going to have to solve for ultimately, I think, as we move towards reference-based pricing. But I just want to acknowledge that that is not a small and just little matter. So we do need to think about that as we try to fix this charge master issue. And then the other thing I just wanted to point out is for the board's consideration is maybe we don't have to think about boiling the ocean. There are certain service lines that are more commonly happening in these hospitals for Medicare patients. There are certain places where the cost share is much more dramatic. Blue Cross is very interested in working with our critical access partners to right size maybe the solution so it isn't the whole charge master, but can be these select services. This will return, this will help for 80% of the market or 80% of the pain or something like that. So I would encourage people to be thinking about steps we can take that don't fall apart from the impossibility of the entire project.
Great point. And just looking at some of the national data, I understand Mr. LaTreco's point and concern about OIG guidance. Essentially you can't rig the system, but it also doesn't require you to rig the system the other way, right? As we look at the national data, there's a lot of states where the co-insurance is quite a bit lower. So there's no requirement on the feds that we take more and more and more intentionally by raising our charge masters to take more out of our community members. So certainly the inverse is not true. So that's just something we have to think about. And at a bare minimum, we should be considering where are the appropriate levels? What would OIG consider acceptable? Because the other states, many other hospitals have not gotten to this point. What did they do and why can't we do it? And what's the schedule if we can, or if it's something that has to be gradual? And I'm not suggesting it should be, but we need to explore those. Dr. Merman?
Sorry, since we're approaching this in somewhat of a work group approach, which I really appreciate, Ms. Heinz, is there a way that Blue Cross could help with some analysis of where specific services could be reduced in charge, but yet maintain, full revenue for these hospitals? That's the goal, is to maintain the revenue while shifting the costs back away from the patients.
Yes, I think we would be very interested in working with the hospitals.
Great.
Mr. Del Treco?
Yeah, thank you. I appreciate it, Chair Foster, and appreciate the conversation here. Some of the other policy challenges that we have in the state of Vermont is, flat or neutral Medicaid payments. We have had our Medicaid dish payments cut in half, and we don't maximize those. All of those put downward pressure on payments to our hospitals and put upward pressure on the commercial side of the equation. So I think supporting we have asked repeatedly year over year, hey, what can we do in the Medicaid space for improving reimbursement? Can we go back to maximizing our dish payment as allowed under the federal government to no avail? All of this creates tremendous pressure. So I think that support needs to continue and carry forward. I know it's budgetary concerns and constraints in different places, but they're real. And I think other states continue to maximize the Medicaid dish payments. They do minor increases to Medicaid payments, which in the long term helps. Imagine if we drew a line through Medicaid increases at, I don't know, some percentage less than inflation. I can tell you we'd be in a lot better place than we are today. So those are other important policy decisions that we continue to deal with today. Thanks.
Put it on the table. We are not the Agency of Human Services or DVHA. We are an independent board. We have our own independent thoughts on these issues. At a minimum, I have publicly suggested that there needs to be a look at how Medicaid is paying hospitals. A lot of what we're seeing are really sensitive services in hospitals, these hospitals that have a large public payer mix and an underpayment on some of the essential services. I don't know that from a policy perspective, I, as one board member, agree with that. So I do think that's a conversation. I think maximizing DISH is a conversation. We should put those on the table. Relating to this issue, I would also note that there is, I will call it at a minimum, a high likelihood that Medicaid is also subsidizing Medicare because of this charge master cost sharing issue, at least for the dually eligibles. So this issue could also be impacting the Medicaid budget. Perhaps if we can solve this issue, we can have a conversation with DVHA and determine whether or not there's a way to use some of those funds that are already being spent in another way. And that's going to bring in another state actor that we need to work with on this. But I think the point is well made. We need to be looking at that as part of the solution because no one wants their critical access hospitals to have financial problems or lose essential services. Mr. Tester?
I have to remind myself to take myself off mute. Thank you, Chair Foster. I likewise want to just express my gratitude for us having a really engaged conversation around this today. I'm probably stating the obvious here, but I was reflecting on Dr. Merman's comment around considering flipping some critical access hospitals to a emergency hospital status. And this conversation can't just happen in isolation. I think that this conversation has to be integrated into the transformation work that your hospitals are already engaged with AHS on, and how we balance changes that are necessary with the need to continue to provide those important services to our communities. And any individual hospital or health system, I can't speak for any other hospital over whether or not it makes sense for their community to change their critical access hospital status. But I will say, I'm looking at the work that we're doing with AHS in the area of transformation in partnership with North Country Hospital, trying to figure out how do we serve the entire Northeast Kingdom? How do we provide the services that these communities need in a sustainable fashion? So let's just, as we're making changes on very narrow and important issues like this cost shift issue, we just have to factor in the larger context of all the work we're trying to do to stabilize and transform the system. Thank you.
Great point. I want to continue and give every board member opportunities because I know this was really an important one for everyone. Ms. Teachout, if you have any comments or questions from your perspective and historical understanding of the insurer side, because we certainly value that a lot.
Thanks. I wanted to start in a slightly different place. I want to ask the hospitals about their financial assistance programs. That was something that I noted in some of the comments about the support that they give to their patients. In particular, I'd like to focus on financial assistance programs and counseling for the Medicare population. So if if more than one of you want to respond, I'm sure they're all a little bit different, but I'm curious about whether you generally counsel patients in advance of providing services and procedures, or if it is generally afterwards when they're struggling with the bills. I'm going to
Mr.
let
Tester?
you chair still, Chair Foster.
Yeah, that's fine. Yeah, Mr. Tester?
Yeah, it's a great question. I would say that I'm only speaking for NVRH, right? But I would say it's a little bit of a mix. We have a program here. It's called Community Connections. It's about 50% grant funded, but the rest comes out of operations. And what we try to do is engage patients and help solve their needs. Oftentimes it's the social drivers of health, whether it's housing, food insecurity, but it's also around insurance and helping them navigate the financial challenges they have. But all that does ultimately feed into our charity care program.
Mr. Frank?
Thank you, Chair Foster. Great question. I'm glad that you asked that question. Thank you. Similar to what Mr. Tester does at NVRH, as you all know, the Northeast Kingdom has the highest rates of Medicare and Medicaid in the state. Our focus is investing in navigators, and our navigators work with our seniors, our Medicaid folks, anyone who needs assistance before, during, and after any insurance issues. Like NVRH, we provide assistance for everything from gas cards to housing to getting folks into the right programs, finding additional insurances, applying for different grants that are available. So as an organization, we invest out of operations specifically in these navigators who not only help our patients, but also help non-patients in our community get on different insurances, including Medicare, et cetera.
Great. So just a follow-up question to that. When I think about how your hospitals are often on the front lines of giving advice, especially financial advice, along with medical advice to your community and the Medicare patients you serve, is it the fiduciary responsibility of the program, your program, to the patient or to the hospital? You know, would you give advice to one of these patients who has no secondary coverage, who could seek care at a different facility and pay a very small amount out of pocket versus at your own? Would you recommend that they go somewhere else?
Mr. Frank?
I mean, what I'll say to that is there's no mandate for us to keep those patients in-house just to quote unquote generate revenue. I think that is a little bit of the gist of the question. If there is a better option for folks, we will absolutely get them there. And one of the reasons we offer gas cards and transportation as assistance is so that they can get to the critical access. In the Northeast Kingdom, and again, speaking specifically to Northeast Kingdom, as the board realizes, we have incredible transportation issues here. So if there's an opportunity for a patient or we need to get a patient to another organization, we'll do that. Our navigators are not instructed to direct patients to North Country Hospital. If there are better options for that patient, we will absolutely recommend and help them get to that destination.
And that's an interesting point, together with Mr. Testers, about the Rural Health Transformation Fund and transformation work that's being done. If there is no, and I don't believe there is no, there's no solution to this at all, just to be clear. And I'm not adverse to the board doing what it needs to do to solve this. In fact, I think we're legally obligated to look very hard at it. But at a minimum, is there a potential to look at the Rural Health Transformation funding and some of the transportation funding to help patients with this issue? And that's a conversation, obviously, you're all having with the Agency of Human Services. But I think it is an important point. There is some care, like Mr. Frank mentioned, that needs to be done at North Country Hospital, either because the quality is good or the patient wants to be there or whatever it is. And there are another set of services that potentially could be done elsewhere, at Mr. Tester's hospital or wherever it may be. Dr. Foster?
Thank you. Hopefully you can hear me okay.
Yes.
Yes.
So yeah, Ms. Ticho, just clarifying, I'm curious as to the reason behind the question. And the reason I'm curious is because I think as a physician, I may be a CEO, but I'll always be a physician first. Our duty is always to do what's right for the patient. So I'm surprised by the question because I've never seen an instance of a hospital ever, maybe in other states, but certainly not in Vermont, where a decision was made what's in the best interest of a hospital's bottom line and not what's in the best interest of a patient. So can you clarify a little bit sort of the reasoning behind why you're asking that? Because I've not seen that as an issue. Certainly Mount Escutney, we will do what's right for patient. Is there an instance that you're specifically referring to, or is it kind of a general question?
It's more a general question. I don't know about how your patient financial assistance programs work on the ground in every single hospital. I'm sure they're different. I wasn't accusing any hospital of not giving a patient good financial advice, but I just want to really know, like, when a patient comes to you and asks these questions, there's more to their decision than just the finances. I understand it's the type of treatment they can receive, what physicians they can see, how quickly they can get in. There's a lot behind these decisions, but the financial piece is big. I do not know if the person who provided the public comment to the Green Mountain Care Board about their knee surgery asked in advance about the financial implications. I really don't know, and if they were able to get appropriate financial advice.
Thank you. And I will say, I think we can do a better job, without a doubt, to be more honest and open, even with small staff that are juggling, wearing multiple hats. I think it's imperative on us to have those honest conversations, not just about what we can do for a specific case or specific patient, but also to understand, what are the implications so we can have shared decision-making, call it what you want. I think we can do a better job with that for sure. And I do want to iterate, since I have the microphone, I think Chair Foster raises a really good point. What can we do with the Rural Health Transportation Funds to that? I think that's an excellent point and part of this dialogue. So thank you. I'll stop now.
Thank you. If there's no more on that topic, I was going to talk a little bit about hospital contracting with health insurers, because I know that's the crux of some of the issues here. I believe that the catastrophic loss of revenue as the result of State Solution A, which was put on the table, is only if contracts with insurers are not renegotiated or moved to a separate fee schedule. So I want to ask, do hospitals renegotiate commercial contracts annually?
Mr. Frank?
Speaking for North Country Hospital, we've never negotiated a contract with Blue Cross. This is the first time in my 10 years affiliated with North Country that Blue Cross has actually reached out for a conversation around specific services. So no, we're handed a professional fee schedule. And then whatever, if there is additional fees that are allowed by the Green Mountain Care Board to be added on, it goes, Blue Cross just accepts those and where we have put them on our fee schedule, and we move forward.
But isn't the professional fee schedule only for the professional fees? So what about inpatient and outpatient? Because we're talking about outpatient charges here, not the professional charges, I don't believe.
So it's both. You asked if we negotiate our contracts with our insurers. So professional is just as important as the inpatient, because one affects the other. If you don't receive an increase on the professional side and you're allocated a % increase by the Green Mountain Care Board, you only have several places that you can actually put it. So if you were to put that increase on the professional side, all you're going to do is write it off. And so from that perspective, they are very much connected. As is the Medicaid dollars that Mr. Del Trecco referred to. It's all a pot of money. It's not just individual. We can't look at just individual pieces. You need to look at the full pot. And again, with respect to, you asked the question, are your contracts negotiated annually? For a small critical access hospital like North Country? No.
Thank you. I'd love to know that if that's the experience elsewhere.
Dr. Foster?
Hey, happy to chime in here too, just to contribute to that. So I've been at Mount Ascutney for a year and a half, so I don't have a lot of experience, but I can tell you that has not been the experience of my predecessors or myself up until this year. I can't speak to Mr. Thomas's 10-year experience, but I can tell you that's not been the case historically at Mount Ascutney, at least in the recent memory.
I'm sorry,
And
I just
so
didn't quite follow you're saying you don't renegotiate each year? You have the same experience as Mr. Frank?
Yeah, and again, I've been at Mount Ascutney for a year and a half, so I just want to caveat that by saying, but historically, at least in the last couple of years, that has not been my understanding of that. So I think it is similar to Mr. Thomas's, but I don't have the 10-year experience that he has.
Thank you. Maybe Sarah, let me ask it this way, or I'll try. Sorry. Does any hospital here, critical access hospital, have a different experience where they do negotiate annually with Blue Cross Blue Shield or other insurers? Okay, hearing, sorry, Mr. Cameron?
Yeah, good morning. At Porter, it's a mix. We do have some contracts, including Blue Cross Blue Shield, that we do negotiate annually. Others are on various longer terms, but specifically, there are a few that are negotiated annually, yes.
Thank you. And I suspect that no one hospital's experience is the same. Are most of the commercial insurance contracts what you call evergreen, which means they continue until there's a change to the contract, or do they end on a date certain?
I'll just keep going. And yeah,
Thank you.
majority of businesses on a date certain contract terms.
Okay. And my understanding, and I'm sure it's not across every hospital, but for critical access hospital outpatient charges, many of them are structured as a discount off charge or a DRG. You may have some separate fee schedules for different services, but I just want to verify that the vast majority is DRG. And I'm not asking for confidential information about your charge masters, just sort of broad general information about your commercial contracts.
Mr. Tester?
Thank you. So just to be clear, our experience with the insurers is similar to North Country Hospital, right? And our contracts are by and large evergreen, and we are percent of charge, not DRG.
Thank you. So I guess I'd like to know, from the hospital's perspective, what is the benefit from keying off a charge master charge for the prices that you negotiate with commercial insurers versus a separate fee schedule arrangement?
Mr. Costa?
I just want to make sure, I mean, what's the benefit of having a single charge master that gets increased by the board's permissible rate increase each year as opposed to negotiating individual contracts with each insurer? Is that the question?
I mean, I guess that's part of the question, yes. And also, is there an advantage to the hospital from one or the other?
I want to be respectful of the fact that, like, one of my other colleagues, I've only been in this seat for a year and a half. My understanding from talking to people that have been at this for a long time at Gifford is one is a capability issue, like the ability to go out and negotiate with multiple parties. Two, getting any of those parties to the table. If you're Cigna, United Health, Aetna, Gifford, respectfully to my colleagues here at Gifford, we're not the most important member of their provider network, though we are important, we believe. And so, the way in which we've done it has worked. We have other operational and administrative issues to work on. And so there hasn't been a lot of consideration of what it'd be like to go and negotiate all of those. I think Rebecca Hines of Blue Cross Blue Shield has made several helpful comments about capability problems within this and how much work it would be. And so I think it's not that it's impossible, it's just probably not been done based on capability and is the juice worth the squeeze to try to leverage a different relationship with insurers?
Mr. Tester?
Yeah, I just want to add some context to this. And one is just the history of healthcare reform efforts, and I'll call them efforts, in the state of Vermont over the last, call it 2 decades. First off, the way we've had the arrangements in payments with our insurers, it's just been historical. I inherited that when I was here. When I joined in 2018, it's the way it was always done. I'll be perfectly honest. I never met Don George until last year, right? Never, there was no engagement with our hospital from Blue Cross Blue Shield at all, really. And that's changed under the new leadership. I'm already seeing much better engagement. We're really looking forward to working closely with, in particular, Blue Cross Blue Shield, because they're the most important insurer in the state. No offense to anybody else, but they're the largest. But in the context, if you look at the healthcare reform efforts, you go back a decade and a half ago at this point, and Vermont was pushing towards a single payer system. And that was the driving narrative. And when that failed, Vermont made the shift with the support of the Green Mountain Care Board at the time to the statewide ACO model. And obviously that did not get Vermont the results that were desired. So there've been a lot of different strategies that kind of avoided the need, or I'll say the need, but the motivation, both on the insurer side as well as the hospital side, to have those conversations. I do see that changing now.
Thank you. And I do want to turn to the one insurer who's attending. And I had a couple questions for you about contracts as well. Are all of your provider contracts with critical access hospitals, specifically Evergreen?
I'm not super duper close to the contracting, but my understanding is that in general, they're all Evergreen. They all have provisions that allow them to be terminated, with various notice. To the point that I think has been made here, a lot of these contracts have been in place for a really long time. And this conversation highlights that it is probably time for us to dust them off and think more creatively about them. I just want to say it out loud. Our system, for better or worse, is set up with this very unhelpful dynamic where you've got the payers trying to keep the costs at the lowest possible, rate so that their products are affordable, and the hospitals trying to stay afloat. And that doesn't always lead to, let's, have a robust, very labor intensive, long conversation every single year to make sure we get it correctly. It's sort of attractive to say, this is working good enough, let's not break it. But I think everybody on this call is hearing, the pressure from the board to be thinking about it through the lens of, the charge master and the damage that that's doing for some of the population. And again, I think we're very interested in working with the different critical access hospitals and trying to come up with solutions that work for both of us. But I said this before, and I want to say it again. If there's a mandate that all the charge masters are at the Medicare PPS rate, and putting aside that would be very, very hard to actually make happen, not every insurer, and some of these insurers are big deals, are going to want to spend the time to negotiate a different deal for themselves than the great deal that is being handed to them on that charge master. So I do think that's something that needs to be thought about as the board proceeds.
And just to follow up with you, I am not sure if you have provisions in contracts that would require a contract to be reopened in the event of a significant change in the charge master, not, a couple percent here and there, but something really significant, either increasing or decreasing. Is that something that would be contained in a normal contract or not?
So we have, as we've been, looking at contracts with a fresh eye, contracting with a fresh eye, we are looking at things like that, where there's more control and more analysis of the charge master changes and how those impact us. There are fees that Blue Cross sets that apply across the board, and to when you hear some of these hospitals say those are just the fees that they're going to get from us, that's a real dynamic. All of this is a ton of work, and everybody's trying to do other things at the same time. So I do encourage the board to be cognizant of the very real administrative asks that renegotiating every single contract every single year might impose upon the different players in the market. But I do think this issue has highlighted, just letting the charge masters be out there without really thinking about some of these other dynamics is a real one. And I think we might be able to find hopefully we can find some short-term, not super labor-intensive solutions that will alleviate some of this problem.
And I have another question for the insurers about the explanation of benefits, or the EOB. I do not know what the federal government requires you to put on the EOB, but my understanding is that generally you show the unnegotiated charge and then the negotiated price to the patient. Is that true?
So are you talking about in a commercial space?
Yes.
Or like on a med sup? Yeah, so it'll have
Commercial
the charge.
space specifically.
Yeah, so my understanding is you'll see the charge, and then you'll see the allowed amount, which is either a negotiated rate or a rate that we set, and by being in our network, you agree to take that rate, and then it'll have, your portion of the cost share.
Is that required by federal law?
I am unaware of a federal law. There are state laws around what needs to be on an explanation of benefits. They're a little bit old. Whether Medicare and Med Sup have a separate regulatory structure, I don't know.
And then is it shown the same way if the charges, and I'm again speaking specific to commercial patients, not Medicare Sup, is paying off the charge master, where it's truly a discount off whatever the charge is, or off a fee schedule where it's a negotiated price that may or may not have anything to do with the charge master?
No, it does not get to that level of detail at all.
Okay. That's helpful. I did have a couple comments when we're thinking about these issues for the board and for all the people who are trying to come to solutions here. And one is about the sort of continued fallacy that I hear, that if health insurance somehow pays a claim on behalf of a patient, that the patient isn't ultimately paying the bill through premiums. And I think Dr. Merman said that, and I also feel strongly that we can't continue to talk about that in that way, because it's not true. And the second thing, and I really did appreciate Mr. Del Chaco bringing up the compliance risks with state action on this. And I recognize that there are compliance risks, but in other areas of state healthcare policy, Vermont has been willing to take some pretty significant compliance risks if it protects patients. And I'm thinking specifically of silver loading, which is an ongoing issue that may not continue to benefit Vermont and our population, but it was an area where we were willing to take a huge compliance risk with the federal government to ensure that Vermonters were able to draw down additional advanced premium tax credits. And I just want to say that that shouldn't stop us from being creative about solutions, although we certainly need to be mindful of the risks for everyone involved. Anyway, that's all the questions I had for now, so I appreciate the time.
Thank you. One comment, Ms. Heinz, on the administrative burden. That is also something we look at in our regulatory processes. We have to evaluate and consider administrative burden. And again, it also relates, though, and it may at times be in conflict with affordability, sustainability, transparency, and all of the other factors. And, here, given that this creates a sustainability risk and actually an access to care risk, it might be something where we need to deal with the administrative burden risk in the best way that we possibly can to solve the problem. I'll turn to Member Holmes.
Great, thank you. This has been actually probably one of the best board meetings I can remember. It's such a healthy dialogue. I love this approach to a working group and trying to, problem solve here. I think there's been some great questions, good answers, and a lot of need for more information is sort of where I'm landing. I'm going to just share some places where I feel like I would need some more information, and then I have a couple of questions for some of the folks on this call. The first is, to me, I need to understand the full impact by hospital. So it'd be really helpful to see. I see that the multiple of the Medicare fee schedule nationally varies from 2x to 11x. It'd be really helpful to actually see that again, the breakdown by hospitals, by critical access hospitals in Vermont. So that would be a helpful piece of information to have as we're trying to figure out and understand this full impact. And also the 4% of cases nationwide where the critical access charge is greater than 5x of Medicare, such that the beneficiary is paying, basically we're subsidizing Medicare and patients are paying 100%. I think it'd be really helpful to know that's 4% nationwide. What is it in Vermont? What are we looking at in Vermont? I think that was on slide 8. Slide 9, and I think Chair Foster alluded to this too. There are states where that the cost sharing percentage is much lower. Alaska, Montana, North Dakota. Is that all driven by charge-basket differences, or is there some other policies or action steps that have been taken in those states to protect Medicare beneficiaries? I think we need to understand that, and that's information I'd love to have as we're trying to problem solve here. Elena mentions specific protections in Medicaid, the dual eligibles, lesser than protections that other states have. I would love to understand that as well. Also, I'd love to probe a little bit if there's I understand there might be a federal solution here. Those take time. There might be a state solution. Those take some time, perhaps less time. We're more nimble. But is there a really immediate short-run solution that involves adjusting the financial assistance policies of hospitals for those, Medicare beneficiaries whose cost share exceeds 20% of, we can pick what that number is, but to bring down that cost share through financial assistance. So I would love to explore that. I'd love to understand how much of bad debt and free care is coming from traditional Medicare beneficiaries who are facing some of these enormous cost sharing expectations. So as we're looking at bad debt and free care, what proportion of that by hospital is that related to this particular payment reimbursement? And then how does that tie back to that Medicare fee schedule multiple, right? Those are sort of my big questions. And I'm going to throw those out there and hope that we can get some answers to those. But actually, given that this is a work group and there are a lot of experts in the room, I'm going to pull a professor kind of thing here at this point. I actually have not heard from the CFOs other than Scott. Thank you. Really, but I see that we've got Cheyenne, we've got Scott, we've got Bob and Andre, we've got Jeff, we've got Kata, we've got Stephen on the phone or on the call. I would love to hear individually from each one of you as you've been listening to this conversation, what possible solutions you see that insurers can take, that hospitals can take, Green Mountain Care Board, DFR, legislature, just give us let's do some creative brainstorming. I'd love each individual CFO to respond. And then what action steps you yourself can imagine taking and would commit to taking in the next 2 to 3 weeks, basically to either learn more or explore a possible solution. So I really would, I value the CFOs on this particular call, and I'd love to hear individually from each of you, kind of what you see as possible solutions and what action steps you can commit to in the next couple of weeks. And I think that will help us move this conversation forward to find a solution for Vermont. So I don't know who wants to start, but at least I think there's at least 8 of you on this call, 7 or 8 of you, if that's okay. I think if we really want to do a work group, we got to put some possible solutions out there and action steps we can take. Scott for the win, A+.
The sooner I go, the sooner I'm done. If we can, clear the regulatory compliance concerns, I think the work is around our fees. And, so we don't have to work with the feds on changing how the calculation work, but the work and the discussion on our fees is very similar to what's going on with the fee-for-service hospitals. And it's very in line with the rest of the affordability conversation. But from a CFO perspective, there's some assurances that I would want to have in place, so there would be this 1-year disruption in our Medicare reimbursement rate until our cost to charge ratio caught up, and various, we all have different days cash on hand, and the ability to weather that one issue alone is big. I would want to know that there was a commitment in the commercial space to have those conversations that you're saying, like how can we be maybe reimbursed differently, but have reimbursement not suffer? What I don't see a path for is that negotiation spreading to payers outside of our direct control within the state. And I don't know how we prevent damage from being done there, as noted by Rebecca, the willingness to renegotiate terms and conditions to keep overall payments level may not be there. So those are my thoughts off the top of my head. And I do this hoping I'm not running afoul with any of my CFO colleagues and their thoughts.
Well, thank you, Noah. Thank you so much for being the first out of the gate. And I wonder if DFR could play a role here, in some of those out-of-state national insurers that we don't. So I think having, for example, an action step could be, reaching out to DFR and seeing if they could help you in that regard. Stephen, or maybe I should let Chair Foster navigate this.
I'm happy to. One comment actually back on that answer, and I appreciated it. The comment about control and oversight over some of the commercial players. The legislature is in session. The legislature is very concerned about this issue, and I guess I'd put that on our list as well. Is there a legislative solution that we need to have to require those conversations or to key off of a fee schedule rather than charges? So I guess we should also put our heads together on whether or not we need to speak with legislators to see if they're interested in looking at that. Mr. Brown?
Yeah, I don't have any specific necessarily solutions, aside from the fact that truthfully, I think Medicare is the one who could solve this problem. If we want to calculate the coinsurance the same for all hospitals, their system could calculate the 20% based on the physician fee, their provider fee schedule, which they already have, rather than all the hospitals trying to come up with something different. That being said, if one of your solutions was that we changed our charge master down to the Medicare fee schedule so that it would be calculated for Medicare anyway, the way you want it, that means we're charging everybody based on the Medicare fee schedule. If we were then to renegotiate with all the commercial insurers, and I'll specifically ask Blue Cross since they're on this call here and probably our largest commercial payer, are you willing to, or is your system even capable of paying us more than what we're charging? Because in order to keep our Blue Cross payments anywhere near what they currently are, if I was sending you a bill with a charge based on a Medicare fee schedule, are you going to pay me more than that, what I'm saying I'm charging? Because you'd have to in order to keep payments anywhere near close.
Yes. So for services that are on a fee schedule, the charge master is not relevant. Just from a technical perspective, I'm not making huge commitments about anything else. But I mean that's not like the charge master just doesn't become a part of the equation if there's a fee schedule for the service.
So currently we're using lab and X-ray as a fee schedule, and I'm sending you a bill, say for $100, and you normally right now are paying me $75. That's fine. But if I'm now sending you a charge that says I'm only charging you $50, but I still want to get that $75, your system will pay me $75, even though I'm only sending you a bill for $50.
Right. Well, I mean, there are, there's deals where there's lesser of provisions, but my understanding is that that a fee schedule can circumvent the rest of it. Yep.
Okay, because I don't recall back when, it's been a while since I've posted remittance advices myself, but I don't remember ever seeing Blue Cross pay more than what we billed.
Right. Well, who would ever do that? Right. So this is a unique situation. Yes, but I don't think it's a technical limitation. Is all I'm trying to say.
Okay. Okay. So then we would have to renegotiate all the rest of the services that are paid on a percentage of charges, and your system would be capable of paying me more than percentage. So instead of paying me 85% of charges, say you're going to pay me 125% of charges.
I think we would set a fee, right? You would say this is the price for this service, and it wouldn't be a function of the charge master because the charge master would be dictating, the Medicare cost share. But
okay, so our entire Blue Cross reimbursement would be based on a negotiated fee schedule, which would be more than what we're actually charging. Your system would be able to do that.
In theory, yeah, the system
Okay.
can do it. It's the devil's in the details, but yeah, I don't think there's a systems limitation.
Okay. That's all I have at the moment.
Well, Stephen, actually, before you go, I'd love to hear what action step you could imagine taking yourself in the next couple of weeks to kind of move this conversation forward. And I would ask that of all the CFOs that are going to speak. I just want to, what are we doing? What action step can you imagine taking?
I'm going to have to think about that. Because truly, I mean, we've been talking now for 2 hours, and from what I've heard, there's no reasonable action steps even been suggested. I'm not able to think of a different one.
Well, I would just say reaching out to DFR, reaching out to the legislature, figuring out the compliance issues. I mean, there's a lot of information gathering that could potentially go on. I'll just throw those out there, but we can hear from other people as well. But there are action steps that I think we all need to take to figure this out.
I agree. I think the biggest issue is, which Mike has said he's already done, is starting with the compliance issue. To me, wasting the time and effort on any other possible solutions until you know what is even legally possible is, we're trying to cut healthcare costs in this state, and that's just going to add to it if we're wasting all this time on solutions that couldn't possibly happen. But that's
Great.
just my opinion.
Yeah, thank you.
Ms. Holland?
Yes, thank you. First, I agree with Scott's statement from earlier. Just kind of thinking about the 1-year issue that with the charge master, because that could create, because right now the reimbursements would be limited to the cost to charge ratio set in that prior year. So there'd be a cash flow disruption in the short term for that could cause a huge disruption for all the organizations. It eventually gets settled. It would be in March of the following year. As everybody was talking, I was thinking about how we could enhance the sliding scale as a short-term solution, especially with the legislated mandates of how much already the state has taken action there, very specifically on what % of federal poverty. Could there be language in there that increases it for seniors specifically, something in that general direction that we could all potentially implement pretty quickly. I know that a lot of our seniors do qualify for a lot of those, but then it could be a lot more just automatic rather than it being on a per, but we have to kind of think about those IRS regs around that too, so we don't run afoul of them. And then at Gifford, we're really interested, and we've talked to Blue Cross, we're really interested in looking at services and where do we move more towards a fee schedule, thinking about, or some kind of alternative payment. We are percent of charge, just looking again, only a year and a half history of Gifford, but it seems to have that stat the same as the other critical access hospitals. It seemed to have been kind of a set it and forget it, because, hey, here's your percent of charge, here's your authorized charge, your rate increase, we're just going to roll that forward without really looking at, does it make sense to go into other services that are, that make sense and really lend themselves to those fee schedules, and starting there. And I think, and the other, just, this is my opinion, I'm not speaking on behalf of Gifford, this is just Cheyenne's worldview, is I think as we move closer to reference-based pricing, a lot of this starts to correct itself. So the quicker we can move towards sort of that, then you'll see some of these anomalies in our charge masters start to right themselves if it's done in a way truly towards a, hey, we're going to be focused on a reference-based pricing model.
Cheyenne, I really appreciate that. I appreciate you trying to throw out some solutions in here. And I just wonder, will you be willing to take kind of those action steps and look into that sliding scale and look into that fee schedule and do that work? And I just appreciate that you're throwing out some real solutions here. So I want to
and in our initial meetings with Blue Cross, we've already talked about some of these ideas going into this contracting cycle. I do want to say that there is the real, like, when you move towards a completely from a percent of charge to some other alternative methodology, it takes a lot of data digging on both sides to make sure there's no unintended consequences, right? Like making sure, like, hey, does this make sense on either side? Like, once you kind of go into that, it's like, wow, we didn't know, they could be paying us 20% more or 20% less. I think one of the other things to consider is also the fact that the national payers, frankly, we have no leverage, and really there, with a population of 600,000 in the entire state, there's very little leverage in general with these national payers from any individual hospital or hospital system. And they're likely to get advantaged as we're starting to. And that's something that, I don't want to speak for my friends at Blue Cross, but I know when we used to do negotiations back in the day when I had my other hat on, that was always a conversation of, hey, Cigna's getting advantage, why are we paying more? And it's because the national payer may just pay that percent of charge without real consideration for what that means for the bigger group.
Yeah, I do think that having the legislature and the DFR involved in these conversations could potentially be helpful in that regard. So, but I appreciate that very much. Thank you for throwing out some real solutions that we can work on together.
I pop in with one quick follow-up with Cheyenne. Cheyenne, if I remember correctly, you have worked at other critical hospitals outside of Vermont, or were they not critical access hospitals?
They weren't critical access hospitals. I've worked in multiple hospitals across different types, whether Medicare dependent, completely public supported, all Medicaid hospitals.
But I guess my second half of the question, which may not make sense, is do you know if the critical access hospitals outside of Vermont typically are percent of charges, or if people have, or if these other hospitals have worked on fee schedules as well? Is this sort of a unique Vermont thing, or is this sort of pretty common throughout critical access hospitals? I think maybe
I don't have that information. I don't have that I don't have that information, Dr. Merman, but I do know, like, if Barry Dunn or somebody is on the call, or who does a lot of critical access hospitals, they might have some insight to that. One of the other consulting firms.
Member Holmes, do you want to, I think you were calling on people in the order in response to your question.
Oh, no, that's right. I wasn't sure if you or I were. I know Andre. Thank you. You're up next.
Hey, Jessica, thank you. Yeah, I agree with everything Scott, Cheyenne, and Stephen have said. You know, I think our biggest hurdle is the compliance piece of it. We do want to be very careful with that. In relation to what Cheyenne talked about with, and what you brought up, our bad debt, changing that, being careful of the compliance issue that Mike Del Checo brought up with trying to manipulate the cost report, because those bad debts for Medicare fall to the cost report and become an allowable expense. So I'm going to call on Bob if he sees anything different as we walk through here, Bob Hersey. In a perfect world, if we were able to navigate this compliance issue, you know, we could potentially put a separate fee schedule for Medicare specifically. You know, Chair Foster was talking about fee schedule and our charge master. We have one charge master, and as you've heard, if we reduce the pricing for the Medicare charges, it reduces the charges that we have for all the other payers, and that results in a substantial hit to the bottom line. Negotiating with Blue Cross is a lot easier than some of these other companies. Your question of percent of charge to out of state, Dr. Merman, the fact that we do have some of those contracts with some of the larger payers that are from out of state would lead me to believe that critical access hospitals in other states also get reimbursed percent of charge. It would be very, very interesting to see the cost difference, the cost share difference, as you brought up, Jessica, from here to other states, and what is driving that. Alaska might be a little different because there's a whole Native American or Eskimo setup up there that might play into that reduction. As far as the solutions, I think, you know, the easiest one would be a separate Medicare fee schedule, and it leaves all the other fee schedules or all the other payers aside. Bob, you want to chime in?
Thanks, Andre. I'm Bob Hersey, no longer a CFO, but still work part-time for NVRH. No, I didn't have anything else to add to your bad debt comments, Andre, but I guess going a little bit out of turn, one of my thoughts is to look at the reasons why our charges are so high, and just to add on to what others have said regarding the Medicaid reimbursement, and specifically the Medicaid tax and disproportionate shared gap. At NVRH, that's $6.4 million a year. So our tax exceeds our DSH revenue by $6.4 million, which is an amount we have to recoup through higher charges. I looked at the 990 for a hospital across the river from St. Johnsbury in New Hampshire. Their DSH revenue exceeds their provider tax by $620,000. Complete flip. So that is a gap that I think is playing into why our charges are high to begin with, and why the Medicare beneficiaries are paying a higher co-payment amount. So solution, you know, work with our legislators to see if we can close that gap between the tax and the DSH revenue. Other solutions, I agree. Oh, sure, go ahead.
Oh, no, go ahead, Bob.
Nope, I was done with that topic, so go ahead.
Well, I was just wondering if that, and I'm not in the legislature, but if, let's just say, that gap was closed, and we've heard DSH mentioned multiple times, if for some reason there was a pathway to close that DSH, would that be enough incentive to drop the charge master? I mean, it seems like if there's still compliance issues and other things, it may not solve that problem. So I'm curious, DSH keeps being raised, but.
I guess my point is, if we didn't have $6.4 million gap to recoup in charges, we could reduce, yes, our charge master by an amount up to 6.4 million potentially. I mean, that's, you know, there's other things to consider, higher costs and everything, but yes, our charge master could in theory be reduced by $6.4 million.
Okay.
And I hope I didn't say anything that Andre or Sean disagrees with.
Looks like Jeff's up.
Well, first, you know, I'm going to probably just basically reiterate a lot of what everybody's been saying, but you know, we got to I feel understand the Medicare compliance issues because any resolution could be overruled by them. The other thing that I would be cautious with is pulling too many levers at once. You know, a lot of you know, we're talking about is working with, you know, the federal payers, the commercial payers. So there's a lot of moving parts, and you know, if we get into this and we're trying to figure out what's going on, and we don't know which lever it was that was pulled, is concerning. The other things that I would love to understand more about ourselves, as well as to supply this onto the Green Mountain Care Board, is making sure that we understand as a critical access what the true impact is to the patient. You know, how much of this outpatient is being paid by them, how much is being, you know, offset by the affordable care that we actually give, how much is being offset by the, you know, discount if they do prompt pay versus bad debt. And then the other piece is the what it means to the commercial payers picking up the co-insurance. How much of that is the Vermont payers versus the non-Vermont payers? It's the non-Vermont payers that I'm concerned with, because you know, we do have, you know, an audience with the Vermont payers to, hey, come back and let's look at negotiations. But I can't go to the national payers and bring them to the tables like I can the Vermont payers. And so those are my thoughts on the issues.
Jeff, let me ask you this. If what legislation would help you gain leverage with those non-Vermont payers?
What legislation? I guess, you know, if we had created some sort of, you know, universal contract that to, you know, that they'd have to adhere to, you know, to look at trying to make that, to try to encourage more, you know, payers to actually enter the state of Vermont would be kind of something that I would be looking into.
Is that an action step that you're willing to take?
Well, if it would be a very difficult action step, but yeah, I'd love to look into that.
Great, sold to the highest bidder. All right, thank you. Kata, I think you're up. Oh, but I think you're muted.
Yes, I am. Sorry about that. I feel like I'm probably restating, or I am restating everything that all the other CFOs have said, including Mike, that for Springfield, obviously the compliance is kind of our number one concern about making any changes. That would be our number one thing to look into first. But as far as changing charges, we, like every other hospital, would have to be made whole on the commercial side of things, because that's a significant impact, or would be for Springfield, as you know, most of our, if not all of our contracts are based on a percentage of charge on the outpatient side. The other concern is on if the charges were changed or decreased, is the impact on our Medicare interim payments, that period of time before the cost report is settled at the end of the year. With Springfield Hospital having the lowest days cash on hand in the state, we're really vulnerable to any cash impact. You know, we can't withstand any ups and downs or any decreases in our cash. So that's a real concern for Springfield. We have seen over the past couple of years a significant increase in our financial assistance, of which about 20% of that financial assistance has been for our Medicare population. So we feel that our financial assistance is helping, you know, the Medicare population. Not to say from Cheyenne's comments that any changes could be made to enhance the financial assistance for seniors. That's definitely a possibility. Probably an unpopular idea, but I'm trying to think out of the box here, and it's probably not a great idea. But is there any kind of mechanism? And I have no idea where the funds would come from, but is there any kind of mechanism to help seniors? And I guess I should say, while this whole compliance thing is figured out, is there any compliance, meaning that, the 20% co-insurance, is still something that we have to abide by? Is there any mechanism to help seniors pay for their supplemental plans, whether at the federal or state level? So I have no idea the answer to that, but that's just something that, came to mind. So I guess those, not really any new ideas, but just wanted to reiterate some of the things that the other CFOs as well as Mike have stated so far.
I guess I just have one follow-up question, and I thank you, Kata. And it sounds like, I think every hospital might be able to look into the sliding scale as a short-term solution. It'd be wonderful to hear from each hospital about what sliding scale changes might be made to provide short-run assistance immediately even. Maybe it doesn't have to wait to think about this. But I would also say I would love to understand how long it's going to take to unpack the compliance question, because that's come up with every hospital, and how quickly can that be answered?
And I would maybe turn to Mike to answer that.
That's great. Looks like Mike's got his hand raised.
Thanks for that question. I wish I had a clear line of sight on that. We reached out to our MAC a week or so ago, and then followed up with CMS, then was moved forward to CMS last week. So I have not heard back over the weekend. I contacted them and via email, not verbally, and I'm waiting to hear guidance and direction back. I will follow up with them. I wish I had a more definitive time period on that.
Great. All right. Well, hopefully we'll have that resolved quickly. I just want to thank all of the CFOs who, I cold called you, and I just want to appreciate that, there were some out of the box questions and some attempts to kind of find a path forward, or at least take action steps to learn more so that we can collectively find a solution here that balances affordability for our most vulnerable rural seniors and the sustainability of critical access hospitals. So appreciate that. Lots of follow-up, it sounds like. And this doesn't have to be the end of this conversation. If ideas are bubbling up, we need to hear them. And I think this hearing was a great idea, or not even a hearing, sorry, this is a working group. This working group in the public, I think, was a great idea. And I hope we can do more of these in the future. That's all I have, Chair Foster.
Prospective Middlebury College econ students are second guessing their decision right now. And having had the privilege and pleasure of teaching alongside you, I've seen the cold calling before. You're an undergrad professor, not the Socratic method that we have in law school, but I appreciate you using it. I'll turn to Member Walsh.
Thank you, Chair. And I'll just reiterate what all of my colleagues have said and say that I think this is the working group approach is terrific. Our staff earlier today presented 3 possible solutions. And the third one, capping what hospitals may collect from patients at 20% of OPPS. I want to focus on that a little bit further, because I think it's the narrowest intervention possible. It doesn't require reducing charges. It doesn't require changes in Medicare payment. It doesn't require renegotiating commercial contracts. It only limits what patients pay. And I think it can be narrowly defined. There are worries about compliance with the OIG guidance. And I guess here's where I have a question that's, I don't know that any of us can answer today. It will require follow-up. But when I read through the guidance carefully, it addresses a specific fraud and abuse worry that a hospital acting on its own can't reduce what patients owe in order to attract referrals or volume. I don't see where it addresses whether a state can enact a consumer protection statute that limits what hospitals can collect from patients for defined services. Those seem like different questions, and I'm not sure the OIG guidance answers the second about what a state can do. There's a hospital choosing to waive a bill isn't the same thing as a hospital complying with a state law. So my interest is to see if there's a lawful state level path that could protect Medicare beneficiaries, particularly those without supplemental coverage and who need services where there are very high charges. That approach is more of a scalpel than a hammer. So I think my question for the work group going forward is there a legal distinction between a hospital voluntarily waiving cost sharing, which is what I think OIG talks about, and a state enacting a general law that limits what hospitals can collect? So I think does the federal law preempt or prevent a state from enacting a law like that? And if not, couldn't we try to not boil the ocean like Ms. Heinz warned against, which I think is great advice? But could we design a regulatory or legislative provision that would protect seniors, but would not be so dramatic a change for hospitals so quickly as to immediately destabilize them? So that's the question that I hope we can keep. That's my contribution to the work group, that I hope we can keep exploring that question. So thank you. Back to you, Chair.
Mr. Del Trecco.
Thank you, Chair Foster, and thank you, Member Walsh. That is exactly the level of question that I've pursued. I've shared all of the public comment information, been very transparent with CMS. I have not reached out to the OIG. I think that is the absolute last resort place. And I'm hoping to hear back. Like I said, I don't have a definitive timeline, and hope is not a strategy. So I will be reaching out to them again. And I think the one point of clarification, if a hospital went to 20%, it would be just for Medicare. It would be financially problematic and not as easy as a transition that you may have referenced. So, but that is the line of questioning, just to reiterate. Thank you.
Yeah, thank you, sir. I appreciate you being here and working with us on
it. And just for my clarification, I believe I had understood the compliance concern, but Mr. Del Trecco, is it primarily OIG guidance around 42 U.S.C. 1320 A7B, the anti-kickback statute?
Well, in the letter that I sent on the 27th, bear with me.
I mean, the one you're referring to today.
No, I'm referring to the OIG comment around, Okay,
we can take it offline. It's fine.
Yeah, thank you.
I prosecuted a lot of anti-kickback statute violations in my life, and I still work on anti-kickback issues very often. And the concern is really about arranging or providing remuneration in exchange for driving healthcare services.
Yeah,
so I think
I don't believe that's what I'm referencing. I'm referencing the what we've referenced in the OIG questions regarding certain fraud and abuse, specifically in July 8th of 2024. where they commented on changing charging to improve or increase Medicare funding into the state, and while putting downward pressure or changing the cost sharing requirements. So that's the specific area. And I can follow up as well.
Yeah, okay. And, OIG has an advisory opinion process. You can always reach out to OIG for an advisory opinion on things, and then it gives you a safe harbor immunity through the OIG. And I have many high-level contacts from my DOJ days at OIG. Happy to discuss and facilitate that if it's a step that's needed. The OIG advisory process is not always the quickest. Oftentimes, clients don't want to go through the OIG process, and you get advice of counsel, and you can go through that way. All right. Let me turn to the healthcare advocate if they have any questions or comments at this time. They may not be on. I know Mr. Fisher was on, but he may have left. Okay. And we have some members of the public here and some health policy experts I see from national sources. So I'll open up to public comment via raise the hand. Mr. Murray.
Yes, thank you, Chairman Foster. My name's Bob Murray. I used to be the executive director of the Maryland All-Payer Hospital Rate Setting System for a number of years. Currently, I'm working with Jerry Anderson from Johns Hopkins. We're funded by an Arnold Ventures grant to provide technical assistance to states that are looking to implement some sort of payment model. I had previously done some work in Vermont, so I recognize many of you, and I want to say hi to folks. This is an issue I've been following just recently. I wasn't aware of it, but it obviously it creates a great inequity and affordability problem for beneficiaries. All of you have been very elegant and eloquent in describing this issue. I've for a long time been really wondering why it is that hospitals have complete freedom to adjust their charge masters. It seems like it's a counterproductive symptom of our highly fragmented and disjointed healthcare system. And so this issue is probably one that just fell between the cracks over time. But it's one that can be addressed. And I think Vermont has a unique opportunity, given your legislative authority, to adjust rates to address this issue. So beneficiaries have been victimized, but hospitals have been victimized by this as well. The hospitals, as has been pointed out here, you're just merely responding to the rules and the incentives in this very fragmented system. And I think that the Green Mountain Care Board has a unique opportunity nationally to address this issue and try to plug the hole and create a more uniform way of paying and a fair way of paying hospitals. So it's very important to address this issue for the beneficiary. But clearly, as you've discussed, you need to be mindful of the revenue impact, particularly on the rural critical access hospitals. So my overall advice is nothing earth-shattering here. I just wanted to commend you and indicate that I think you have a unique opportunity to address this distortion that exists. That is the charge flexibility that hospitals have to increase their charges. Again, they're just responding to the rules and the incentives, so they're not doing anything untoward. But the Green Mountain Care Board has the opportunity to try to address this fragmentation issue that has resulted in this affordability problem for patients in your state. And I think it's something that Vermont can be a leader on, and it will have implications for other states. I'm doing some work in Washington and Oregon as well. They have many rural critical access hospitals. So just wanted to make those comments, just commend you on this process. I think it's a very collaborative process, which is great. But the board needs to preserve its independence in making its own final judgment on this. And I just wanted to make those comments and go from there. Thank you.
Thank you very much, Ms. Murray, for attending and providing your national landscape and perspective to us. It's always valued here at the board. Mr. Costa?
Yes, really good to see Bob Murray. When you were executive director for the Maryland Health Services Cost Review Commission, what actions did that commission take to address this problem?
Well, there are two, I think, particular circumstances that affect Maryland. One, we didn't have any critical access hospitals in the state. When Maryland started regulating hospitals, the rural, isolated, smaller hospitals fell under the rate setting system of the HSCRC. So this issue did not come up just because of that dynamic. But we also set charges. The HSCRC had the regulatory authority, still does, to set charges, and that influenced what all payers pay. There was a uniform markup from the net payment to charges. They're very closely aligned in Maryland. We just had the advantage of being able to set charges and rates back starting in 1977, when there wasn't this big disparity in pricing and charges across payers. And so overall, we've had the ability through the regulatory system and a collaborative process with hospitals, such as you're going through here, to try to rationalize the reimbursement system and protect patients, but also protect hospitals. So I think you have a similar opportunity here, given your authority, and it just appears that this dynamic that you've created in this work group will allow you to get to a mutually acceptable solution for all parties.
Thank you.
Thank you very much. Any other public comment at this time? Ms. Raymond, MP?
Yes, hi. I'm a member of the public here today, and with so much talk about Medicare beneficiaries, I was thinking that perhaps maybe the next work group session, it might be a good idea to invite somebody from the Council on Aging, just somebody from the broad network that we have. The Healthcare Advocates Office is one piece of that, but I think it would be very good to hear their input on that. And to a great extent, I also worked in the free clinic system for a very long time, helped a lot of patients apply for financial assistance. Certainly the seniors are often reluctant to apply for it, but especially now with the passage of Act 119, we've seen huge growth in that. So I think that the charts and the graphs I saw at the beginning could be a little bit deceiving. I also know most of the seniors that I worked with they were insurance poor, just paying for Part B and their Part D plan. So I think that the financial assistance is a huge piece. It's very important, and Vermont is very generous with their financial assistance piece, much more generous than our counterparts in New Hampshire. I know that for sure. So I would just say I think that would add a lot of depth to the conversation and maybe bring some insight and some thought into how we could proceed further with the discussions.
Great suggestion. Our board hearings are always noticed, although sometimes we can do an improved job on reaching out to specific groups to try and ensure attendance and participation. So we will note that, and we'll make sure that we do that for the next work group session. Other public comment? Okay, hearing none, I would ask for the hospitals and VAHS to provide us feedback by tomorrow morning, if possible, on the request for what guidance would need to be and what kind of language would be acceptable to at least note and put on notice that the board will be evaluating this issue. Hopefully there'll be a solution that we can come to, but otherwise any input that you want to provide on guidance would be great. Mr. Del Trecco?
Yeah, as I alluded to at the beginning, I don't think I'm able to respond for tomorrow for guidance. I think it's too soon and too early. I think there's been a lot of discussions and questions here that I'm surprised, a little bit surprised that we're asking for information to be put in guidance when we've just went through a whole process of questions and answer without answers. So as I alluded to in my opening remarks, unfortunately, I'm not able to do that.
Okay, the opportunity is yours to take it if you'd like it, and it is on the table. We have to vote out guidance by the 31st. This issue's been before the board. It's important. And guidance is just to provide notice on this issue. And if there's particular things that you'd like, we appreciate the feedback. But if not, that is okay. I do want to make sure that you have the opportunity, though. Mr. Del Cecco?
Yeah, thank you for that. There are many things that we could consider. And I do have, not because we have had this meeting today, but I do have an executive committee meeting just routinely scheduled, and this will certainly be part of that conversation. I think the things that I would think of out of the gate, one would be, how do we want to respond as this work group to the compliance issues that have been raised? Secondly, how do we want to put in guidance solutions for our underfunding of Medicaid and DSH payments? I think those are areas that are really important. And then moving forward, some critical or other things that came into light today are around how can we more positively put out the work that we're required to do around transparency. So those would be the things that I would be speaking to Chair Foster. As far as specific recommendations to solve the crux of the issue we're talking here, I'd be challenged to do. But I hear you loud and clear, and I appreciate the opportunity.
Okay, great. We do have a little bit of old business that I want to wait, which is just some meeting minutes. The board had hearings on March 11th and March 18th. So I will move to approve the minutes of March 11th.
Second.
All in favor of approval of the March 11th meeting, say aye.
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 Minutes are approved. And I will also move to approve the minutes of March 18th.
Second.
Second.
All in favor, say aye.
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 And the March 18th minutes are approved. Any other old or new business for the board? Then I want to thank everyone for the communications that we've been working on to get this issue teed up for us to discuss it today, for the time out of your busy schedules, and for the efforts to try and address this and solve it as soon as we can for the communities, while ensuring our hospitals are very solvent and sustainable. So thanks everyone for your work. There are a number of things that we need to take away and work on, and we appreciate your efforts. With that, I will move that we adjourn.
Second.
All in favor, say aye.
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 Aye, and we are adjourned. Have a good day.
Thank you.
Thank you.